Hi everyone, my name is Laura Gryder and today I'm going to be talking about pertussis. So pertussis is also known more commonly as whooping cough. It's caused by a bacterium called Bordetella pertussis, and you can see a slide of that right here in this image. The disease progresses through 3 stages. The first stage is the catarrhal stage. And that can last anywhere from 1 to 2 weeks. The symptoms include runny nose, low-grade fever, mild occasional cough, and you become, towards the end of this stage, highly contagious. What's kind of dangerous about this disease is that the beginning stages of it look like the common cold, so it kind of slips through the cracks. The second stage is the paroxysmal stage, and this lasts from 1 to 6 weeks. It can go into 10 weeks, and the symptoms just get worse. You have rapid coughing followed by a whooping sound. This is because you're coughing over and over again, and you aren't giving any opportunity to breathe in. So after you have your fit of coughs, after that point, you have an intake in breath, a large so that's where the disease actually got its name, from the whooping sound that they make, trying to recover from the coughing fits. During this time, you could also, you may vomit, turn blue, stuff like, from lack of oxygen, stuff like that. Stage 3 is the convalescent stage. This lasts about 2 to 3 weeks, and so you're no longer contagious at this time, but you are susceptible to other respiratory infections. So say if you get a cold or something like that, it's just going to happen more easily because you're recovering. So Bordetella pertussis is transmitted indirectly, person to person, via airborne droplets, and it's called Flugus droplets. These are just pathogen-containing particles. So transmission occurs that way. There's an incubation period of 7 to 10 days before symptoms will show, but it can come as early as 4 days after exposure to 21 days after exposure, so that's the window there. And as I sort of mentioned in the previous slide, the transmission period, the catarrhal period, begins in the catarrhal period, and it can go on into the first 2 weeks after a cough onset. So symptoms and complications. So as I said earlier, you have this spasmodic coughing, followed by the characteristic whoop in recovery, trying to get your breath. Apnea can occur when you're laying down, because you have all of this mucus in your respiratory system. Cyanosis, that just means lack of oxygen, makes you appear blue on your lips or your face. And it's because you just aren't getting enough oxygen. You aren't able to breathe because you're coughing so much. Post-tussive vomiting, that can occur from really violent fits of coughing. You may vomit. And again, at the very beginning, of pertussis, you have cold-like symptoms. And in some cases, particularly infants, you can have acute encephalopathy, which is brain swelling. So this is a potentially very dangerous disease, particularly so for very young infants. So fatality rates for pertussis in 2014 in the United States, according to CDC data, you have the highest amount of deaths in infants aged 3 months or less. 8 infants died during that period of time. You had 1 infant between 3 and 11 months, 2 children between 1 and 4 years of age, and you actually had 2 adults over 55 years of age that died during this year, for a total of 13 deaths in 2014, which is still high considering this is a vaccine preventable disease. Globally, in 2008, there were 89,000 deaths from pertussis, and in 2014, you had a total of around 140,000 cases of pertussis. And globally, we have at this period of time, so in 2014, about 80. Polymerase chain reaction. Testing can be done normally about one of three ways, as you can see here. The gold standard is the culture, where you actually can take a swab from the nasal cavity and you culture that, and that takes around 3 days. So it's not as swift as another form of testing, polymerase chain reaction, PCR testing. But it is more accurate. So if you want to confirm a case epidemiologically, you need to have a culture. But PCR testing is fast. You have a really fast turnover, and if you're a doctor and you just want to see what's going on with your patient, you're going to want to use PCR, and it's also used epidemiologically. Just cultures are the gold standard. There's also serology, which can be used, and this is done later. So how do you treat a case of pertussis? How do you treat someone that's been exposed to pertussis? Well, there are 3 recommended antimicrobials to combat this disease. So as it's a bacteria, of course, antibiotics do work against it. So you have azithromycin, clarithromycin, and erythromycin. So instead of treating a patient that got pertussis with antibiotics or antimicrobials, the better option is to never contract the disease in the first place. And the best way to do that is to be vaccinated. So there are currently 4 vaccinations available on the market. 2 are meant for pediatric cases, and 2 are adult and adolescent boosters. They are all for acellular vaccines. Cellular vaccines are no longer approved for use in the United States, just because they are not very effective, and particularly over time. In about 5 to 10 years, a cellular pertussis vaccine really won't have the protective benefits that an acellular vaccine will. So the 2 vaccines, pediatric vaccines on the market in the U.S. are Infanrix and Dapticel. And you are going to get, as an infant and a child, you're going to get 5 doses between the ages of as early as 6 weeks. And then your last final booster with the DTaP will be around 7 years of age. The Tdap, so tetanus, diphtheria, and pertussis booster, you have Boostrix and Adacel. So again, these are meant for adolescents and adults, and they're approved for, the first one, Boostrix, is approved for use amongst people 10 years of age and older, but Adacel is only approved for. So I spoke about the dosing, the vaccine recommendations. Well, dosing is really important for pertussis protection. For infants and children, you get 5 doses total. Four doses occur at 2 months, 4 months, 6 months, and then the 4th one is between 15 and 18 months, but the first dose can be administered as early as 6 weeks. And the fifth dose is the booster, and you'll get that between age 4 and 6 years of age. And this is normally this is required in most states to be admitted into kindergarten. So you really have that encouragement and that motivation to have your child vaccinated before they go to kindergarten. Adolescents require a booster, or a booster is recommended rather, between the age of 11 and 12 years. And a lot of schools, again, have made this a requirement in recent years due to vaccine preventable diseases in schools breaking out. Adults, their recommendation is to get their booster done every 10 years. And as you would imagine, that doesn't always happen. Pregnant women are the last group that are really targeted for vaccination for Tdap. And it's recommended that you get your vaccination, your booster vaccination, during every pregnancy, ideally during week 27 to 36 of your gestation. And this is the best way to transmit immunity to your infant. Vaccines vary in how effective they are. Pertussis vaccines, so DTaP and Tdap, do vary in their efficacy. So you have an efficacy range of about 80 to 85% according to the CDC. One study from 2014 looked at a pertussis outbreak in Oregon, and they found that the efficacy rate was about 95% for children aged 15 to 47 months. So it's pretty high. Of all the 100% of children that got the vaccine, 95% were protected. It's a different case for adolescents. So children between the age of 13 and 16, of those who got the vaccine, so I'm going to say that this was Tdap, 47% were protected. So it's a much lower efficacy rate for this age group than the younger children. But the authors make sure to stress that being vaccinated, no matter what, is better than not being vaccinated. So they just did a relative risk comparing non-vaccinated children to vaccinated children, and they found that non-vaccinated children had a 1.9 to 20.9% higher risk of contracting pertussis when compared to vaccinated children. That's the range, the confidence interval. It's important to adhere to your vaccine schedule in order for the vaccines to be the most effective. And this includes boosters. When you don't comply with your vaccine schedule, and again, this includes adults, so every 10 years adults should be getting their booster vaccine for their Tdap. The fact that so many adults are non-compliant and they don't even realize it leads to an endemic level of pertussis present in society. And this is actually the point source for a lot of infant illnesses of pertussis. Pertussis in an adult really might not be a very serious thing, but pertussis in a child really can be. So vaccination is key, and adhering to your vaccinations. So one way of determining vaccine coverage is to look at groups where you're going to have the data. And since vaccination is tracked for children in school, that's a good place to go. So the CDC actually looked at DTaP vaccinations among a sample of children enrolled in kindergarten in 2014 to 2015. And they looked at all the states, and they even looked at some, specific cities in some cases. And I pulled a few numbers from this study of interest. So the median coverage for vaccination was around 94.2%. That's pretty high, pretty good. Nevada wasn't far off. About 93.2% of our kindergartners were fully vaccinated, so all 5 doses. But the range was a little bit different. Colorado was quite low at 84.3%, and then you had Maryland, which was absolutely stellar. Nearly all of their children were fully vaccinated at 99.6%. Of interest, when you look at the medical exemptions column and the non-medical exemptions column, the non-medical exemptions column, you'll see that both Nevada and Maryland do not have philosophical exemptions. It's not allowed in our law, but Colorado does. And here's just a map from that same study showing the vaccine exemptions around the country. So white data wasn't collected. You could see Nevada's pretty low, about between 1 and 2% of is the estimated percentage of children enrolled in kindergarten who were exempted from receiving either one or more vaccinations. So this isn't all the vaccinations. It might have just been, a single vaccination, say if they had an allergy or something. Is isolation or quarantine required for cases of pertussis? The answer is no. Isolation may occur. So say you have an infant who's really sick with pertussis and they're hospitalized. They're probably going to get a private room, especially if it's with their room would have been with other children, other young children or infants, because they would be susceptible and vulnerable to pertussis. But really, you're just gonna use droplet protection as a healthcare practitioner or as a visitor to anyone with pertussis. If you have pertussis and you are visiting an ambulatory facility, you're just gonna be told by your doctor to follow standard precaution. You might be asked to wear a surgical mask, but really just being hygienic, not coughing all over the place, maybe being escorted directly into your examining room. Those would be the things that would happen, but pertussis is not the kind of disease where you're going to be asked to be isolated in your home, like Ebola, potentially Ebola, or certain other. So what do you do to control infection? What if there's an outbreak? What if you're exposed and you're not up to date on your vaccinations, or you don't have any vaccinations? Well, in order to control a disease outbreak, you're going to want to have accurate and swift case identification. And the first step in this is PCR testing. While it's not the gold standard, it's quick, it's fast, and you could move on immediately from there. During an outbreak that you know of, it's really important to administer post-exposure prophylaxis to anyone who has been exposed, but you're going to want to prioritize pregnant women and infants. And you won't want to wait for lab confirmation to do this. You're just going to immediately administer, a suite of antibiotics or one of the 3 that I mentioned, or maybe multiple ones, in order to So here are just a few epidemiological definitions. So the clinical case definition of someone with pertussis is in the absence of a more likely diagnosis, so like a cold or something like that, a cough illness lasting greater than or equal to 2 weeks with one of the following symptoms. You have paroxysms of coughing, or inspiratory whoop, or post-tussive vomiting, or apnea, and that's with or without cyanosis, blue tinge to your skin, to your face, to your lips. And that apnea one is only for infants aged 1 year, less than 1 year. What are the laboratory criteria for diagnosis? Well, I touched on this earlier. You need to isolate B. pertussis from a clinical specimen, so this is your culture. It's clinical research, it's not laboratory. So as we know, there are different levels of case classifications. You can be probable or confirmed. For a probable case classification, you can either meet the clinical case definition as outlined in the previous slide, but your case is not laboratory confirmed and not epidemiologically linked to a laboratory confirmed case. So if you meet those qualifications, you are a probable case. It's slightly different for infants. So if you're an infant less than 1 year only, if you have an acute cough illness of any duration with at least one of the following signs or symptoms, the coughing, the whoop, the vomiting, or apnea with or without cyanosis, and you're PCR positive for pertussis. Or, so same group, for infants less than 1 year only. To be a confirmed case, so what is the surveillance for pertussis? The majority is passive surveillance, so it's a reportable disease to your local health agency, which then sends it to the state, which then gets sent to the CDC. But there are definitely some cases of active surveillance. As we know, active surveillance is more expensive, so it's not going to happen as often. One example that I found came from a program initiated in Cyprus, and in this outbreak, and there was an outbreak in Cyprus in 2003. They actually detected the outbreak early because they had begun active surveillance of rare pediatric diseases and had included pertussis in their So, who is the highest risk for contracting pertussis? Um, well, obviously, as I've spoken before, infants, less than 6 months old with less than 3 DTaP shots, they are at the highest risk. Adolescents and adults are also at risk, those who do not have their Tdap boosters, but they really aren't going to have the severe adverse health outcomes that often happen with infants. And you have the same high risk groups globally as with the U.S. It's just there's probably going to be even more cases outside of the U.S. with lack of access to vaccinations and timely vaccinations, so to keep on your schedule. A study from 2000 looked at children with vaccine exemptions and without vaccine exemptions, and they found that pertussis was higher in children with vaccination exemptions versus no exemptions. It makes sense. The relative risk was actually 5.9 for those children with the vaccination exemptions. We actually found, or that study actually found that pertussis in vaccinated children who were in counties with higher rates of exemptions versus counties with lower rates of exemptions were also had a higher relative risk. So they were 90% more likely to get, these vaccinated children were 90% more likely to have pertussis than other vaccinated children in a county with, lower rates of vaccination exemptions. So these vaccination exemptions affect everyone. They found that schools with outbreaks of pertussis, when compared with schools without outbreaks of pertussis, they had a higher prevalence of vaccine-exempted students. So there were 4.3% of vaccine exemptions in the schools with outbreaks, and the schools without outbreaks had 1.5% exemptions, and that difference was statistically significant. So historically, when you think back on what pertussis was like before the vaccine, so the vaccine was created in the 1940s. So this was actually a very common childhood disease. I remember, watching movies about this era, and they would talk about whooping cough. It was a very common thing, and the data actually shows that 5 out of every 1,000 children born would die of pertussis in the early 20th century. That's unbelievable. In 2014, the incidence in the So what's the burden of pertussis? Well, in the U.S., according to 2014 CDC data, you see that age is the most significant demographic variable affecting pertussis incidence. So the crude incidence shows that the highest rates are among the age group 11 to 19 years old. You have about 33.8% of all pertussis cases fall within that age range, and the lowest is among 6 to 11th month olds, 2.7%. But when you adjust for age, the incidence rates show the groups that are actually truly really affected by this disease. The highest incidence is among infants less than 6 months of age, so 169 cases per 100,000. And the lowest incidence is among those who are 20 years and older, about 2.2 cases per 100. What's the global epidemiology? Well, there's been a resurgence in recent years of pertussis, just like in the United States. In reaction to this, some have founded a program called the Global Pertussis Initiative, and just some of the facts about the global epidemiology of pertussis are that infants that are under 6 weeks of age have the highest burden, and that's because they have 0 protective shots. Infants that are less than 6 months of age also have a high burden, as they have less than 3 shots at that point in time, so they're still vulnerable. The recommendations of this initiative is one, to have more pregnancy vaccinations. This is going to help protect the child once they're born. And barring that, or in addition to that, you have a phenomenon called cocooning, and this is essentially getting everyone that is going to have any contact with this infant, with this neonate, to get fully vaccinated so that they are not exposing this child to this deadly disease. The global burden in developing countries, so there's about 300,000 estimated deaths out of 50 million cases. And there is a 4% case fatality rate in infants, all for this vaccine preventable disease. So I already spoke a little bit about the demographic distribution of age and how infants and neonates are disproportionately affected by this disease. But what I didn't talk about was that there actually is a race ethnicity component to the distribution of this disease. There's a higher incidence among whites than blacks, so you have about 3 per 100,000 cases in whites to 1.4 per 100,000 cases in blacks, and that's across all age groups. And what's also interesting is that there's a higher rate of pertussis among Hispanic infants. So of Hispanic infants, of all pertussis cases, about 29% are Hispanic infants. But Hispanic infants actually only represent about 18% of the population. So there's something disproportionate going on there. Seasonality. Pertussis isn't particularly seasonal. You don't really see a spike in winter months like you do with the cold, but you do see. So here are some cool maps that I found. The one on the right is from 2008 data from the CDC, so it's a little bit old, but it just shows the average annual reported whooping cough cases per 100,000 population. So you see Nevada's kind of low, around 2 to 4 per year per 100,000. And as with, it kind of maps on to that other map that I showed earlier of exemptions. You see Colorado's really high, Washington, Oregon, they're really high. It maps on pretty well, actually. On the left is 2014 data, so definitely more recent data of incidents of reported pertussis by state. So I highlighted Nevada, which is of interest to us. We have 5.2 per 100,000 cases of pertussis in 2014, which equals about 144 cases. On the low end, you have West Virginia, which only has 1 case per 100,000, so 18 cases in that state. And Montana at the other end with 48.7 per 100,000 cases of pertussis, and they had 494 cases there. Pretty crazy. The global geographic distribution of pertussis is really hard to find because really the only way that I could get at this data was by looking at DTaP vaccinations. So that's you can see that vaccination rates are the dark blue. You have greater than or equal to 90% of the population has their doses. Their DTaP doses. So you have the developed quote unquote countries, the high GDP countries, and then you see a lot of places in Africa, India, Mesoamerica, the Asian Pacific Islands. They have fairly low rates of DTaP vaccinations, so they probably make up a large portion of the case data that I mentioned earlier and the fatality data for pertussis. This was a really interesting piece of data that I found from the European Union, um, from their Center for Disease Control. So they looked at a number of their countries. They're only missing a few, like Germany, I believe, is one of them, and no, they have lots more. So they show the crude rate per 100,000 population for males and females from different age ranges. So 0 to 4, 5 to 14, 15 to 24, 25 to 44, 45 to 64, and over 65. And what I kind of thought was interesting about this was that across all groups, females have there are more confirmed cases of pertussis among females. Given that I wasn't able to find any differences in gender anywhere else, this was perplexing to me. So the CDC has been collecting data on pertussis since 1922. And this graph represents that. So you see 1922, and on the axis you see number of cases, starting with 50,000 and going up to 300,000. And the rates are pretty high in 1922. And then you see around 1940, the DTaP was initiated and available to the United States public. And you can really see how the rates just drop significantly after that, and were pretty much flatlined for a number of years. And then towards the end of this period in time, you have these bumps in pertussis rates in the 2000s. And what about age over time? Well, this chart is cool because it's incidence rate per 100,000 again, and it's from the year 1990 to 2014, but it's broken up amongst significant age groups to this disease. So less than 1 year, 1 to 6 years, 7 to 10, 11 to 19, and 20 and over. And you can see, as we would have imagined, those who are 1 year or less are more affected by this disease than any other group. Again, following the theme of time, you see with this CDC data that pertussis has increased in disease rates from 2003 in the light blue to 2013 in the dark blue. These are new cases per 100,000. And some of the reasons for that are varied. You have anti-vaccination groups, which contribute to this phenomenon, but then you also have, I think more significantly, people not paying enough attention to keeping up with their boosters. So the earliest mention in the literature that I could find to whooping cough or pertussis came from Scotland in the Middle Ages, where they referred to whooping cough as the kink or kindhust. And most of those phrases really referred to, again, the whoop that sufferers would make after their cough. So that's a line that's connected us through the ages. The first recorded outbreak occurred in Paris in 1578, but whooping cough or pertussis really isn't, like the Black Plague or like Ebola, because it is an endemic level, like of adults, especially of adults that have pertussis for a period of time that are just static in the population. You're not as likely to see these outbreaks as you would with other diseases. Resistance to antibiotics and waning immunity is definitely an important topic that needs to be looked at more now and in the future, because this is going to increasingly affect our ability to fight this disease. There are strains of pertussis that are resistant to the antimicrobial drugs that we currently use to fight it. So again, we're always gonna need these antibiotics. So we're either gonna have to find new ones that can fight this disease that is evolving, um, or better yet, we try to reduce new incidences of pertussis. But that gets difficult when we have new strains of pertussis that don't contain the antigen protactin. So protactin is exuded by the toxins in pertussis and by the bacteria. And the vaccine actually uses that protactin to recognize that there is the bacteria in their system and to fight them. So you get your vaccine, say you do come in contact with pertussis, and protactin is recognized, and the vaccine, gets your immune system to fight it back. But there are some pertussis strains out there now that they found that don't exude this, that don't have this antigen. So there's no way for this vaccine to recognize this disease in your body, and the pertussis could still sweep through your body. So this could be one of the reasons why we are seeing higher pertussis rates in recent years. And as I've touched on a little bit over the period of this presentation, anti-vaccination groups are definitely contributing to the problem. If you have groups of people that are scared of vaccinations and believe that it is harming their children, and or maybe they do get vaccinations, but they don't get it at the right time. They do it slower. They do one at a time. They do it, months between what is actually recommended. This puts their children at risk, and it's not likely that they're getting their vaccines either. So they're contributing to this rate of pertussis endemic in the population. And when they have children that they aren't vaccinating, and when these people are grouping with each other, this leads to a greater likelihood of a disease outbreak of pertussis and other diseases, other serious diseases like measles and mumps. So, anti-vaccination groups are certainly contributing to the problem, but what I've discovered through my research is that keeping updated is on your shots, even though the efficacy is questionable for Tdap, is essential. Better to get it than to not, and to get it on time than to get it decades later, because you could be saving the life of a little helpless child or someone that doesn't have a fully functioning immune system and can't get the vaccine even though they want to get it. So in short, vaccinate. And I hope Matthew McConaughey vaccinates too.